Welcome to Progenesis Academy webinar, session 42. Today's topic is fertility preservation option for cancer patients. We have invited 4 fertility specialists, experts in fertility preservation. Introducing Dr. Chen, Director for Reproductive Medicine at IRMS St. Barnabas Medical Center. Dr. Maas, Fertility Specialist at Idaho Center for Reproductive Medicine. Dr. Brown, Medical Director at Brown Fertility. And Dr. Richlin, Partner and Surgical Director at Reproductive Medicine Associate of Connecticut. Thank you so much for joining us.
Thank you.
Thanks for having us.
Yeah, thanks.
Well, my first question has to do with the impacts of cancer treatments on fertility. And you know, when patients take radio and chemotherapy, and the question is, what does that do to fertility? And I'll start with you, Dr. Chen.
So what does the birth control pill do?
Yeah, the idea of using cryopreservation is to minimize the impacts of chemotherapy and radiotherapy on fertility. So if you can give us a little bit of, background of what that impact look like. So for patients who is taking
the birth, first of all, a lot of people worry about the birth control pill because they're worried that it's associated with an increased risk of cancer. And we don't really have strong evidence that there's a significant increase in the risk of cancers with birth control pills. In fact, birth control pills can significantly lower the risk of ovarian cancer, and by a tremendous amount. And of course, birth control pills, while they are used as contraceptives, have many, many non-contraceptive benefits. And one of those is in high-risk patients who are high risk for ovarian cancer, to potentially lower the risk for ovarian cancer. There have been some studies done on using birth control pills to suppress ovulation and therefore try to preserve their function. It seems like the ovaries are senescent either through birth control pills or GnRH analogs. Antagonists haven't really been studied, but significant ovarian suppression, there is some data that possibly this might protect ovarian function against the impact of chemotherapy and radiation, but the results are pretty mixed. So it is, we have a lot of experts here, but it's not my first choice in terms of fertility preservation. It's certainly not unreasonable. There are some people with cancers who their oncologists are not going to want them to be on the birth control pills. And of course, cancer patients do have higher risks of DVTs and clotting. So we have to think about that as well, because the birth control pill could be additive in terms of those risks. So birth control pills, there's not really a simple answer. They're not all bad. They're not all good. I think it has to be an individualized decision. Does that answer your question?
Yeah, and I'm sure we're gonna go into more details in the next few discussion questions. Dr. Maas, if you could
Yes.
tell us about the impact of chemo and radiotherapy on fertility.
Yeah, sure. I think at least for women, they're born with a fixed egg supply, and that decreases over time. There's with different types of cancers, there's different types of treatments. Some of those may involve surgery, and depending on the type of surgery, it could have a direct impact on, the reproductive organs. In terms of chemotherapy, a lot of the chemotherapeutic rate, not all of them, but, there's variability in terms of the type of agents that are used that can impact the egg supply. There's variations in the type of dosing that's used. And so it's hard to predict the impact those medications are going to have on the egg supply. But, depending on how good the egg supply is going into chemotherapy, if a person takes like a fractional hit in terms of their egg supply, it's hard to know what the fertility potential of that patient is afterwards. So certain types of chemotherapy, for example, are known to really be problematic, like cyclophosphamide, some of the alkylating type agents, some of the platinum agents, maybe not quite as bad as the DNA alkylating agents, also can have a pretty significant impact. And given that variability of a patient going into it, and then the effects it's going to have on the egg supply and the residual egg supply afterwards, it's hard to say what the patient's fertility potential is going to be afterwards. You know, on top of that, a lot of chemotherapeutic regimens use radiation treatment, and you know, depending on how localized the treatment is, how close it is to certain reproductive organs, that can also have an impact on a patient's egg supply. You know, and I'm talking about women because most of us have a background in OB/GYN, but it's similarly with men too, in terms of the chemotherapeutic exposure and radiation, surgical risks that go along with it. So it can be difficult to predict what sort of recovery someone's going to have after they're exposed to chemotherapy, surgery, radiation. So then it kind of raises what can be done either before treatment or during treatment to help to preserve the options for someone to have a family. And I think part of it is, you know, now that treatments for cancer survival rates have been improving for a lot of different types of cancers, you know, I think some of the attention's shifting just from getting through the acute, you know, trauma of being diagnosed in the treatments and starting to think longer term in terms of quality of life type questions. And then, you know, at the top of that's usually, you know, what are we going to do about having a family and what impacts are these treatments going to have? So, you know, knowing the risks that go along with these help us to maybe counsel people and kind of explore options to help preserve long-term fertility options for some of these patients.
Thank you so much. Dr. Brown?
Yes, I agree. I think you have a wonderful staff describing, you know, the insult to the gonads with chemotherapy, radiation treatment, surgical treatments, and patients that have cancer. There are lots of different insults, and a lot of it is also gauged by age. If the younger patient, they seem to do a little better than older patients in a reproductive sense. And we have some tools that help, you know, birth control pills and different agents to help maybe mediate some of the potential damage from chemotherapy or radiation treatments. And then, and then we have other options to consider freezing eggs or embryos and sperm. So we, you know, I think we're in a good place where we can treat, we can help these people.
Yeah, thank you so much. We're gonna go into the possible options for preservation, but we're at the stage where we just want to get some definition for the patients.
Sure.
Dr. Richlin, if you could also define that for us, the impact on gonad or just on fertility in general when it comes to taking radio and chemotherapy, and maybe you can also elaborate or define what preservation mean or cryopreservation mean in this context.
Right. So, you know, chemotherapy agents can be rough. And like Dr. Maas said, the alkylating agents, for example, are very strong agents. And, you know, how I look at it is that these agents basically stop cancer cells from dividing. And so that's how they stop cancer and try to put it at bay. But also our ovaries and the follicles and the eggs are also growing tissues. And these agents can be rough on women's follicles, and they can stop cells from dividing. They can cause atresia and apoptosis and make eggs really be damaged and put people into what's called premature ovarian insufficiency, and also kind of hurt the vasculature of the ovary. So, and like Dr. Brown said, it depends upon how much you use, what agents, if you're young, if you're older. And the real nice thing now is these patients have such great options. And what I'm seeing in my community is the oncologists know where we are, they know who we are, and they know to have their patients who are about to have chemotherapy talk to us. So for example, the classic patient who has a breast cancer before chemotherapy or surgery, they will talk to one of us and they can very quickly go ahead and do cancer preservation, which would be freezing eggs or freezing embryos. And it kind of depends where they are in their life. So some of our patients want to freeze eggs. They want great control of their eggs and gametes. They don't want to add in a male partner. Other patients are partnered. They want to freeze embryos. So it kind of depends where they are in their family building, if they're going to freeze eggs or embryos. And the beauty is that all of our patients should know is that we can help them do this quickly. And all of our centers are set up to get them to CS fast, to stimulate and do IVF, get eggs, go to retrieval, and then do fertility preservation, eggs or embryos. So it's a field that's really moving forward, and we're doing great work with it.
Thank you so much. Let's talk about the different type of fertility preservation options available for patients and how you determine which one is more suitable for those patients. We're talking about options ranging from the most common procedures like egg and embryo cryopreservation to your more drastic ones involving ovarian tissue removal and preservation. Dr. Chen, can you talk a little bit about this option?
So this is, I think that is a good point, that everybody should have a conversation about all the options available. But the bottom line is, given the current technology, if somebody has gone through puberty, then the best option is to freeze sperm or to freeze eggs or embryos, because just the pregnancy rates are just very high. So with vitrification, in 2012 and 2013, ASCO, the American Society for Clinical Oncology, and the American Society of Reproductive Medicine looked at the data and said, vitrification is so extremely successful. This new method of freezing is so successful. It's like pressing the pause button, and it would be crazy for us not to tell everybody to think about freezing their eggs or embryos if they can. So we, as a field, we've switched over to doing that. And the data on, like we said before, on birth control pills and GnRH agonists for ovarian suppression, that is definitely a very, very much a second choice when it comes to provable success rates and live birth rates and fertility preservation. It doesn't mean it's not unreasonable. And certainly the big thing is a patient should see one of us, somebody who's, a fellowship trained, board certified reproductive endocrinologist who really does this every day. And then they can really understand the process. And I always say to patients, this is your body. ASCO, everybody wants you to know about egg freezing. That does not mean you should freeze your eggs. What we want for you is you want to be in a position of being very well informed and having no regrets about your decision. And it's not for everybody. Just because we can doesn't mean we should. So that's the thing that we struggle with, is that not every patient that should be thinking about freezing their eggs who has cancer gets the opportunity to actually get this information and talk to somebody who can actually do this and really tell them, what it's about. So I think that's the big deal. Now, tissue preservation or ovarian, like taking out the ovaries and freezing them, or doing ovarian strips and freezing them, that is a choice for somebody who has not yet gone through puberty, because it definitely does. The pregnancy rates seem to be much, much lower, and there's much less data in terms of success rates of making babies with that method. And so those methods are usually only done for pre-pubertal ovarian preservation, and that is a little bit less clear, because if you're pre-pubertal, you have some protection from a lot of these conventional chemotherapies. Pre-pubertal treatment with chemotherapy and radiation tends to cause less damage. So that's one consideration. And then it's more invasive, obviously, to get ovarian tissue than to do a simple egg retrieval, which is just a needle-guided procedure. It's not a surgery. So a lot of different considerations. And it's very difficult to freeze eggs and then to freeze ovarian tissue and then to thaw it and get it to ovulate and get it to make a baby. That's very, very difficult, and is mostly done only at large academic centers where they're, following these patients through an IRB. So I'm in New Jersey, and we send those patients, to Cornell, because they have a study protocol there. So, and there's a big, big center at Northwestern. They've had a lot of success. So it's not something that is at every single IVF center, whereas retrieving the eggs through IVF is available at every good IVF center all across the country. That is a much more accessible option.
Thank you so much. Dr. Richlin, can you talk about these options as far as your practice? How do you handle all these options? What is the most suitable for patients? And whether you have that ability to do the most drastic form of preservation, cryopreservation?
So we are doing a lot of, obviously, egg freezing and creating embryos with or without embryo testing. It really depends upon what patients want. Some of our patients who come in, let's say with a cancer and they are not partnered, a lot of times they're just going to freeze eggs, which gives them great opportunities and great options. They freeze their eggs. It can take, less than 2 to 3 weeks. It's really simple. Get out their eggs and freeze them or vitrify them. We would love them to have more than 15 eggs to be frozen, and they can use those later after they do their chemotherapy and get healthy and get clearance. They can use those eggs, make embryos, and put them back into their uterus just in case their ovaries aren't working well. Also, we have patients who want to make embryos. Let's say they're married and they're going to have chemotherapy and or surgery. They'll make embryos and they'll be frozen, do their treatment, and then when they're healthy and happy and ready to go, we can thaw those embryos and use them. A lot of times we'll do a split. Sometimes we have couples who are together and I say to them, you know something, I know you want to freeze just embryos, but if you two don't continue and you don't make it through as a couple, I would like you to have some eggs frozen so that you can have those just in case you two as a couple don't make it through. I don't want you to be stuck with that gentleman's sperm. So there's a lot of different ways to do this. I agree with Dr. Chen, the ovarian tissue banking, where we're doing laparoscopies and taking out tissue and freezing it and then putting it back into the body to create pregnancies down the road, is more specialized, and that's happening under IRBs. All I would say is that most of our centers are really well-versed at seeing patients and getting them quickly into treatment and doing IVF retrievals and making eggs or embryos.
So much. Dr. Brown?
Yeah, I agree with the panel that we have the easier options that we're all well suited to with egg retrievals and embryo creation and cryopreservation of eggs and cryopreservation of embryos is pretty established for all of us, especially in the post-pubertal woman or post-menarcheal female. You're right, the current challenge is the pre-menarcheal female. With the big push from ACOG, they really want us to freeze ovarian cortical tissue more so in that population, or the older patients, post-menarcheal patients that just don't have time to go through a controlled ovarian hyperstimulation to get eggs. So there's a big push, and ACOG has made it very clear that you don't have to have IRB protocol, even though most of us want IRB protocol for this. They've actually given us a loophole. They said that we can do it without IRB, and but not so much with like testicles and younger pre-pubertal boys, and that they need to be under IRB. But we have a little bit of a loophole where we can be aggressive with ovarian cortical tissue freezing, and it's kind of in its infancy. But it's nice. We have lots of options. We have cortical tissue freezing, we have egg freezing or vitrification, and embryo cryopreservation. And also our medical options such as pre-chemo, pre-radiation treatment options and some surgical options to help in those that choose not to use these options to help them preserve future fertility.
Thank you so much. Dr. Maas, can you talk to us about your current experience with cryopreservation?
Yeah, I mean, I think along with the other physicians on the panel have much more. I don't have experience with working with the ovarian cortical tissue. So if a patient came to me requesting that, I would refer them to a center that had experience. I think in terms of oocyte cryopreservation, embryo cryopreservation, I think one of the discussions, I usually will have is just make it clear what the difference is between those two types of cryopreservation techniques. I guess kind of the analogy I make for my patients is it's a little bit like having two different insurance policies that you have different amount of information and pros and cons for. I think like Dr. Richlin was mentioning, if you're just freezing eggs, you don't have the legal issues with parentage rights afterwards. The eggs belong to the woman, and So if there's any uncertainty, that's the way to go in terms of kind of parentage rates down the road. I think at the same time, I think egg freezing technologies improved, but there's still a little bit more attrition with the freeze thaw of eggs. So I think it's important for patients to realize, egg freezing is now a very good acceptable technology, but there may be a little bit more attrition with the freeze and thaw of eggs. I think patients also need to understand, just having an egg, you don't necessarily know how the egg is going to perform after it fertilizes. So there's a little bit of unrealized potential with freezing eggs. You don't know exactly how the eggs are going to perform until you have those embryos and have a pregnancy with it. I think if it's a couple, they're certain they're going to be together. There's certainly more certainty with working with blastocysts, because there you have eggs that have been fertilized fresh. You've seen them make it to day 5, day 6, they've survived, because there is a natural attrition that happens. Not every egg fertilizes. Not every fertilized egg is going to make it to a blastocyst. And there's some variability, some patient-to-patient variability with that process. So if you have blastocysts that you can freeze, there's a lot more certainty in terms of what the reproductive potential you're going to have with those embryos is going to be. And especially if patients choose to do Pgta testing, they know they have chromosomally normal embryos. They know the gender of the embryos. I think you have a fair amount of certainty of what the potential chance of success with those frozen embryos is going to be. So, usually when I see patients, I have that discussion just so they're clear what the pros and cons of those two, the most accepted, the preferred method. I think at the same time, like the other physicians are alluding to, you may not have time. Like I've had some patients with leukemia who are real sick and there's just not time, or maybe they're coagulopathic, and we'll all go to the hospital. I'll have the discussion because I feel like the patients deserve to at least have the information, know what the impact could be on their fertility, and know, even, we're talking about egg freezing, embryo freezing. If a patient doesn't choose to do that and they've had impacts on their egg supply, there's other options potentially if they beat the cancer to have a family, like donor egg, donor embryo, surrogacy. I think at the very least, even if a patient doesn't choose to pursue these treatments, having that discussion, I think gives them, it kind of focuses a little bit of a long-term picture. And I think the patients really like that. It's like we've beaten, we want to beat this. We want something to look forward other than just talking about cancer.
Yeah, very positive conversation. What are we doing after you survive?
Yeah.
Giving hope and energy.
I agree.
So, Dr. Chen, you mentioned in your first, in your last answer, that the most common form of cryopreservation is egg and embryo freeze. So, in those cases, how long do you think a patient who has gone through chemo or radiotherapy, how long they should wait till they start again trying fertility, whether naturally?
So that's very individual, and I think Dr. Brown and Dr. Maas and Dr. Richlin all talked about like different agents and chemotherapy and radiation and how they impact the ovary. The truth is, they're right. We really don't know exactly how fertile somebody is going to be when they're ready to try again. And a lot of that will depend on the patient, but it also depends on the oncologist. And, one of the most common cancers we deal with is breast cancer. And now we are seeing some of the oncologists want people to stay on some sort of hormonal chemotherapy for 5 years, 10 years even. So we are seeing even patients with, what we consider low risk chemotherapies that supposedly are not like cyclophosphamide or these alkylating agents that really kill a lot of eggs. If a patient even has a very gentle chemotherapy, if she has to wait 5 years before she gets pregnant, that in itself will dramatically reduce her reserve of eggs. So I feel like since we really don't know what somebody's original fertility is or what their fertility will be after cancer, that the fertility preservation really should be available to everybody. And then I have to say, I do have a bias against embryo freezing and for egg freezing. Everything Dr. Maas said is very true, that you get more information, But, you know, we have a 50% divorce rate in this country, and the divorce rate in cancer patients does tend to be a little bit higher in all chronic diseases. Anybody going through like a big thing like cancer, the divorce and separation rate tends to be higher. And once we put the sperm and egg together, we cannot take it apart. And we really want people to have, you know, be able to make their own decisions at some point down the road. And that's the problem with freezing embryos. So Dr. Arash, I'm not sure, did I answer your question? Like I started talking so much. I can't remember if I did I answer your question?
You did answer my question. Thank you so much. Yeah, so now let's move to the next question, which is now looking at these patients who really, you know, determining the timing for starting a new IVF cycles really depends on each patient and each situations. If you add to that the type of cancer that they are going through, maybe there is a metastatic cancer, the chance of recurrence and all that, how do you take all that into account? And I will take Dr. Brown.
Sure, it's a good question. It's a complicated answer, I suppose. It's very individualized for sure. You have a patient with a vicious lymphoma that really has no time or very little time to pursue fertility preservation versus a patient with a low stage breast cancer that has a little longer time to go through fertility preservation techniques. So it's very individualized on what type of cancer, how ill is the patient, and the age, the pre-menarcheal, post-menarcheal patient. So it's nice that we have options for all of these age groups, and we do have options now to move fast or move, you know, somewhat normal paced. But it's very individualized. But a lot does hinge on the patient's current health with what type of cancer she has, and what kind, and then trying to gauge how much time do we have to act. Yeah, those are some big issues.
Thank you so much. Let's take Dr. Maas' opinion on this.
I might, if you're okay with it, I might answer the question a little bit tangentially. Like, I think that probably, in my opinion, I'd be interested to hear what the other physicians think, but probably the biggest variable in time, I think the biggest variable in some ways is the oncologist's knowledge to have that discussion with the patients and send them to us. Because I think that's the thing I kind of worry about the most, because if, you know, I think it's really easy for the oncologist to get really wrapped up, and, you know, and the patient too. It's like, we need to beat this and we need to go as quickly as possible. Yep. And there's never that discussion that, hey, there could be consequences to what you're about to take in terms of your long-term, you know, family building potential. And so I think there's that barrier. And I think there's also the barrier, like talking with some of the physicians in the community in terms of their thought, how long it takes to do this. So they're, oh, you know, I think a lot of the, like, and I think it's definitely improving, but, you know, when I first came to Boise, a lot of the oncologists are, oh, they have to be on birth control pills for a month, and then we need to do this and that, and it's going to be a month and a half or 2 months. And, you know, like, you know, the protocols now, we can basically start at any point in the menstrual cycle. Yeah. And as long as, you know, a 2-week delay in starting chemotherapy, and in the case of a lot of cancers, that's an acceptable delay, we can get eggs and either freeze eggs or freeze embryos. And I think that making sure the oncologists know that there may not be the need for a large delay, and know to have that discussion and send them to us to talk, makes a huge difference in the patient's access to all of this.
Absolutely.
Thank you so much. Dr. Richlin, can you address the same aspect, and maybe we can go into a different question?
So my experience where I am is that the oncologists actually call me on my cell phone directly, and or they know exactly how to get to me through my practice. And, you know, the bottom line is like Dr. Maas said, we can stimulate people and get out eggs at any time of their menstrual cycle, at any time they walk in the door. So that's so exciting. We can do this. A lot of it depends upon where the patient is at with their oncology team. The oncologist will tell us, hey, listen, this is an aggressive cancer. We want to do our magic on them soon, so you don't have a ton of time. Or they may say, hey, listen, we have some time, there's a couple months. and you have a little bit more time. Based upon that, it's really easy for all of us to get these patients in our system, get them comfortable, have them see our reproductive social workers, get them a little bit of talking, meet our nurses, for us to help them get their medicines and teach them how to use it and get it done. So a lot of it for me is, what type of cancer is it? How much time do we have? And you know what? We're always working. We're always open. The lab is always open. We can put in into cycle and we can do this.
Thank you so much. Dr. Chen, do you have the same type of synergy with physicians who are handling cancer
yes,
patients?
but it took a long time. Like I did the same thing as Dr. Richlin. Like I spent years basically just handing my cell phone number to everybody I spoke to. So like I'm like constantly doing talks and trying to say, listen, this is my cell phone, just text me. And they will. Like now the oncologists are so much better than they used to be, and they're more comfortable. They didn't used to be comfortable. And now I'll get texts from them in the middle of a patient consult. They're like, I'm sitting with a 23-year-old now. Can she come upstairs? And I'll be like, yeah, send her upstairs. Let's do this, because we can get the counseling in. We can start the grant programs to cover the egg freezing, right away. And I also think we should not put all the burden upon this conversation upon the oncologist's head. It is definitely part of what they are supposed to do. It is part of their guidelines to talk about fertility preservation with all their patients. But sometimes patients don't get to the oncologist until later. And all primary care doctors, everybody on the street, all of us, friends and relatives, everybody should know, well, oh my gosh, you might have cancer. Like, find an oncologist, but find a reproductive endocrinologist too. Do it at the same time. Let's just get all these conversations going, get the information, because we don't know how much time we will have. So I think, yes, the oncologist should have this conversation, but sometimes they are not seen till much later in the process, after all these surgeries and biopsies and things like that. And all the other doctors, everybody in the healthcare system, our whole society really should be trying to help these people get the information they need, sometimes way before the oncologist. But
Dr. Brown, how's your experience working with oncologists? Do you think they are equipped and conscious about fertility options or cryopreservation when it comes to having patients in that situation?
Perfect question for me. And your panelists are spot on. The number one hurdle for fertility preservation in cancer patients, in my mind, is the medical oncologist. They're, at least in my community, their education, their comfort level in referring patients and getting the team activated, like as Dr. Chen was mentioning, there's a significant reluctance to refer the patient. For multiple reasons. In my mind, I think number one, it's ignorance. They're in general, I think medical oncologists, at least in my region, they want to blame estrogen and progesterone on a lot of cancers. And to me, there's a brainwashing that we need to re-educate in our medical oncology partners, that we're not worsening their stage of cancer. We're not. But there seems to be a reluctance to send patients. I don't know if it's out of ignorance or bias. For example, we'll see the oncologist, especially the younger, in my mind, more educated on medical oncologists. So they know they need to do this. They knew that fertility preservation needs to be part of the conversation, and they'll go halfway. They'll say, "Hey, they'll call us and get them in right away." We all open our doors immediately to these suffering patients, and but then on the second half of their interaction with the patient, they kind of back off, saying, "Well, we don't want to give you any time, or the cancer could worsen and lead to death." And I understand that's their bias. They're used to dealing with patients that die more frequently than we are in women's healthcare with reproductive endocrinology and infertility. But to me, that's our number one hurdle, is educating or convincing our G1 oncology team, the medical oncologist, and referring them and feeling comfortable with that. I think we all get them in quickly, and then educating the patient. And then the number two hurdle is, they worry about finances. You even hear the doctor paternalistically say, how much is it going to cost the patient? So they worry about the cost of the issues. And so I think there's a lot of education necessary with medical oncologists from our perspective, and then looking at an overall perspective as a team approach. But that, in my mind, that's the number one hurdle to deal with.
Thank you so much. And maybe the oncologist, first priority is the health of that patient, and they don't see maybe the fertility, they see it as secondary, or maybe they don't see it.
So Nabil, you know what I did? I did rounds and with all the medical oncology practices in my area in the last years, and kind of went over what Dr. Brown is saying, hey, listen, we're here. We want to take care of them, and we can do this quickly and refer them so we can help them. So like Dr. Chen said, it's just getting out the message that we're here for them, and it's so important to at least talk about it.
Yeah, exactly. So let's talk again about the success rate when it comes to oocyte and embryo cryopreservation. And I'll start this time with Dr. Maas first. What is your success rate looks like, and then after we can talk about the other aspects of cryopreservation.
Sure. I think that a lot of it depends on the age of the woman. Usually when I'm counseling my patients in terms of what the outcome is for if we have time to make blasts or freeze eggs, I'll usually quote them kind of similar results that we have kind of for the same age match group that we work with that doesn't have the cancer diagnosis and the kind of the time crunch. So, and usually I think that's, in terms of counseling that I give my patients, that's usually information I give them. So for like patients less than 35, I usually tell them that, for average success rate for a pregnancy is going to be about 45-50% if we're working with embryos, and, kind of somewhat similar for eggs. I think a lot of it just depends on, their age and how much we get out of the cycle. And I think once we see that, it's probably even a little bit easier to counsel on what the chance of success is going to be.
Very good. And I'm going to ask you, Dr. Chen, the same question, but I'll add one more component, which is, I'm sure it seems obvious, but some patients will worry about impacts on birth, having gone through a tough treatment. So if you can tell us what the success rate is and whether there's an impact on birth.
I think it's we have a lot of data from from egg freezing. We have a lot more data from egg freezing now. Obviously, having embryos can give you could say each embryo, if it's an untested embryo, around 50%. If it's a tested embryo, maybe 60-65% take-home baby rate from each embryo. But we're seeing with our frozen egg program, for every 6 to 8 embryos, at least 2 nice looking blasts, and for under 35, that would be 50% per blast. The hard part is breast cancer patients tend to make less eggs. And we can't predict this. Like I had a patient who froze like 100 eggs. I mean, admit she was in her 40s, and now she's very happy, but she didn't have a baby with her frozen egg. She had a baby with, a donor egg. And I have a patient who froze just 1 egg, and in her late 30s, and failed a bunch of IVF cycles when she came back and then finally used the egg, and now has a baby from the 1 egg. So I think we should give them general prediction rates, but I think this conversation is more about just being proactive about improving your chances of fertility success with your own eggs after you survive your cancer. And I forget, I think Dr. Maas or Dr. Richlin or Dr. Brown said earlier, Dr. Maas did, even if, we don't freeze eggs, or even if the frozen eggs don't work, the conversation with the reproductive endocrinologist hopefully will give the patient hope that whatever challenges you face in terms of your infertility, we have some solutions for you. You may not like all the solutions, but we can basically make a baby for anybody if let us. So the technology is pretty incredible.
And my question was, in the context of having a history of therapy, of chemo and radiotherapy, does it change the outcome?
Well, that's the whole reason to try to do the fertility preservation before you do the chemotherapy, before anything is in there. Now, the cancers, I think cancer does sometimes have an impact upon egg production, especially things like breast cancer, but it doesn't seem to increase, it doesn't seem to impact the outcome other than it can lower the egg yield. That seems to be, you know, the biggest impact. Chemotherapy and radiation themselves potentially can cause issues, which is why, like, you really shouldn't get pregnant right after chemotherapy or radiation, because theoretically you could have an increased risk for birth defects because of the impact of these things directly upon the DNA. Does that answer your question?
Yeah. And I'm going to ask the same question to Dr. Brown. So, these patients have gone through therapy and their, reproductive tissues have been affected in some ways, and you're going to have to, transfer an embryo in that same environment after some sort of recuperation. What do you see any impacts in your opinion?
Yeah, from my opinion, the uterus is pretty easy. The endometrium, and unless the uterus had radiation, if it was a chemotherapy patient, usually there's no permanent damage to the uterus. So implantation and receptivity is usually not altered. Now, we typically have these patients have a maternal fetal medicine pre-pregnancy approval, and the general state of health of the woman is important. Was she on agents that affected her heart? Other medical important lungs, for example. So will the pregnancy tax her from a obstetrical perspective is important. But I think, in general, the patients do pretty well. The uterus is easy to work with typically. And it's more of the patient's age and overall general medical health can play a part, especially in the second and third trimester. But in the first trimester, I think we have great success. I think the endometrium is spared, and so it's more of a maternal concern. I don't think there's an increased risk of miscarriages depending on the age of the egg. I think so. I think in general, implantation and pregnancy rate should not be altered from the woman's stated age.
Thank you so much. Dr. Richlin?
Yeah, so a lot of really, really good comments. Right now, I have a couple patients who actually froze their eggs, had breast cancer and got treated and are doing great. And like Dr. Chen said, a lot of these patients are actually on, let's say, tamoxifen. What their oncologist will do is we'll say, you know what, we can stop the tamoxifen for a little bit, and then we can make embryos, do an embryo transfer. Patients do very, very well after chemotherapy and embryo transfer and do just great. The uterus is usually not affected, and they go on to do just amazingly. So I think after someone is better from their cancer treatment, they can get pregnant on their own. If they get pregnant on their own, guess what? If that pregnancy goes out of the first trimester, it's likely to be just fine. That meant they ovulated a good egg. And if they come back to use their eggs or embryos after their treatment, that is just going to make them so excited, so happy, so much energy. We can do an embryo transfer and help them family build. And the last thing, like Dr. Chen said, family building for all of our patients, there's so many great options. And like you said, Dr. Chen, I bring up, egg freezing, embryo donation, adoption. Like you said, we have so many tools. If they want a family build, but it didn't work with egg or embryos, there's still other great options to really have a good family life.
Thank you so much. Dr. Maas?
Yeah. And I think that, I think I echo everything else the panel's saying, and a lot of different options for patients. I think one other thing maybe to add, like one question I get occasionally is, say I don't choose to freeze eggs or embryos, and say my egg supply is okay and I do get pregnant, is there an increased risk that my child's gonna have birth defects or something like that? And as far as I'm aware from the literature, there's not an increased risk of congenital anomalies or anything along those lines. So if a patient does have chemotherapy and maybe they make it through and their egg supply isn't compromised to a point where they can build their family, I think that the data suggests that if they do get pregnant, like Dr. Richlin said, likelihood if it's an ongoing pregnancy, there's probably not an increased risk for other problems associated with the pregnancy.
Thank you so much. Dr. Chen, let's talk about cryopreservation of ovarian tissue for pubertal girls. Is this something you've done in the past or you're considering to do?
No, it's not something that, like we talked about before, our center does not do that because we consider that to be really specialized. And you want to give these people the best chance at success. So this would be something where usually you do it laparoscopically and they're removing ovarian cortical strips. They have to be preserved in a special way. And then the really, really hard part is after, when you're ready to have them back, is implanting them back. And they've done different things like implanting in the pelvis, reimplanting in the pelvis, reimplanting in the arm, and then hopefully ovulating on their own. But the removal, the preservation, the proper handling of the tissue and the reimplantation is actually something that, is not really common at a lot of centers. So it's definitely much more invasive, and there's just a lot less data. So if you look at how many IVF babies we have maybe 7 to 8 million IVF babies born since 1978. There's maybe a few thousand babies born through the current vitrification technology. The old technology was very slow freezing. Very few babies were born because we just were not good at it. But the more recent data on the vitrification, we are seeing more babies, but it's a lot less than the fresh eggs. And then the number of babies born from ovarian tissue cryopreservation and reimplantation is maybe like a dozen or so. So it's very exciting, and there are some successes, but so much less data. We definitely need to. That's definitely something that needs more study and more work. But there are big centers all over the country that do this. It's just not something that most fertility programs commonly have right in their center. But everybody knows somebody that we can refer to if we need to.
Yeah, and you can work with them, right? You kind of, because at the end, the patient will come back to you in some ways, or to you or to another.
Oh yeah, absolutely. Like, if we send to New York, we're like about a half an hour outside of New York, but we can do all the monitoring, all the testing. Absolutely.
Very good. Dr. Brown, did you have any experience with this type of procedure in this age group?
I do, and we just started the program for tissue freezing, and it's been interesting with its challenges. It's very new. And getting it's a challenge overall just for the G1 oncologist just in general to embrace what we do. But this is even taking it up a couple more notches. I enjoy the fact that we don't have to have this under IRB protocol, even though we plan to. ACOG has kind of given this that loophole, but we have a lot of experience with freezing early on, and so we're excited about it, and we're doing it.
Fantastic. And I would like to ask you, Dr. Richlin and Dr. Maas, the same question, and if you can touch on why the cryopreservation for ovarian tissue is still considered experimental. You can maybe answer both questions.
Well, I'll just, I kind of echo what Dr. Chen said. There are centers that are doing it. There's investigators who are doing it. There's, few babies born with it. I don't know if the number's under 200. It's complicated. You're doing a laparoscopy. And there are centers who are focusing on it. And I think they should be doing that. We should be doing, we do well. And I think with time and technology, tissue cryopreservation will pick up steam, but I don't think it's there right now. But I'm also on the East Coast like Dr. Chen, so patients who need that, we refer them to a center that is focusing on that, and that's how we handle that.
Very good. Dr. Maas?
Yeah, pretty much the same. I don't have any personal experience with, harvesting ovarian cortical tissue. Again, I think if we had a patient, you want to help provide the best care for the patient possible. So you want to send them to a place that has experience and has done it before. usually I'd refer them to a tertiary care center like UCSF or Oregon Health Sciences. I think there's also the question, there's the topic of kind of the transplantation of tissues. There's also the topic of kind of in vitro maturation of oocytes, which is also something that's, I think, it's still kind of in its infancy in terms of success. I'm not aware of any success rates with the technology. Maybe there's been something, but it's something that, again, is something that would be considered experimental.
Yeah, and I want to just have a follow-up question, which for me is more of an interesting aspect, which is when you look at orthotopic implantation of ovarian tissue versus heterotopic, and we've seen cases where ovarian tissue was implanted in completely different parts of the body, under the arms or under the skin, and it does, seem to be restoring the activity of FSH and LH, and it has been some, pregnancies and deliveries. What do you guys think about it? And if you can give us the scope of science going forward. I'll start with you, Dr. Chen.
So I think that's very exciting. And of course, now, like, we're growing fetuses in Ziploc bags, right? And at some point, we're not really going to have to worry so much about ovarian tissue cryopreservation, because at some point, we're going to just scrape some cells from our skin and drop them in a little envelope and mail them to Amazon Genomics. And Amazon Genomics is going to make some eggs or sperm, or maybe make both, and then you're just going to design your baby. So I think the ovarian tissue cryopreservation is very exciting, but there's all this other technology that we are probably going to be able to make eggs soon, like just make some eggs.
Yeah.
So I don't know.
So
that's my thought.
Thank you. Dr. Brown, what's the horizon of science in cryopreservation?
That's the dream. The prayer is that we could take a somatic cell and de-differentiate it and create a sperm or an egg from a differentiated cell. That's Dr. Howard Jones's dream just before he died in his last lecturing. And, to have an artificial egg or artificial sperm or artificial uterus, that's the dream. We're all pushing toward that, which is great. The current focus is now, the new thing is to cryopreservation of ovarian cortical tissue. And I think it's new. It's I'm glad we were through the phases of egg freezing or cryopreservation, and we went through the initial phases of that. For heterotopic implantation, the fellow that was a year behind me, Dr. John Schnorr, won the prize paper at ASRM for that. In the monkey model in Norfolk, they put the tissue in the monkey's arm, and they were able to get eggs and get fertilization of the and for the last 20 years they've been trying to do that, and it hasn't really taken off. But I think now with ovarian cortical tissue harvesting, I think we're gonna, in the next 5 years, we're going to see much more of this. And I'm anxiously awaiting more and more success from this new process, and it works. And then coming up with ovarian tunneling and orthotopic placement of the tissue back to the ovarian remnant, and it's an exciting time. And I think we're going to have great success.
Fantastic. Dr. Maas?
Yeah, I know, like with the kind of the holy grail of kind of pluripotent stem cell redifferentiation. I know the group that the papers I've read have been out of a group in Japan. I think it was published maybe around 2013, and they've successfully been able to get kind of epidermal cells, de-differentiate them back to a pluripotent state and redifferentiate them into either oocytes and sperm. And they have successful mouse babies with it, which is pretty fascinating. It's pretty incredible. Again, I think there's the ethical issues that are going to rise up with that. But if something like that happened, you basically have the holy grail of fertility. It's like every cell is a potential source for oocytes or sperm, and that would be fantastic. In terms of, I think looking at the paper, one of the challenges, and I think it's one, and again, I don't have any real practical experience with cryopreservation of ovarian tissue, but from my understanding, one of the challenges is apoptosis, loss of cells with the freeze thaw, particularly when they were looking at redifferentiating these cells back into either oocyte or sperm, the efficiency of that process was really low. So, there's more work in the field to be done, but if they can crack that in human cells, which then, that would be amazing. From what I understand also with the cryopreserved tissues, in terms of the transplantations, there is a fair amount of, potential loss in terms of the follicles that may be associated with that can be a challenge. But again, it's technology. This is stuff that's all in its infancy. Technology.
Yeah, we're going to get there someday.
Yes, things improve. I think you're going to, I think like Dr. Brown said, this could be something that becomes really available technology that's much more widely used and available to people. Maybe someone doesn't have the 2 weeks to freeze the eggs or embryos, but they could have surgery, 1 day of surgery to get it before chemo starts. That would be, I think open up even more options for some of these patients who are at least hemodynamically stable enough to do it, but may not have the luxury of time, even kind of the shortened IVF stems offer,
Thank you so much. Dr. Richlin?
I agree with some great comments, but if you think about it, our field and the technology has just gone wild. In our lifetimes, all of us on the screen, we have seen, IVF, pregnancy rates improve, and embryo testing and Pgt go way up, and freezing eggs and vitrification. Guess what? Ovarian cortical strips, we know it's not efficient, but guess what? With time, we're going to get better and better and better. Think how that's going to be in 20 years. There's so many cool things that are happening. There's going to be so many options for these patients. So I like you said, Kevin, I think it's interesting. Some patients don't have the time. Maybe ethically, they're not interested in doing IVF. They want to take out some ovary tissue, freeze it, and use it down the road or topically. I think it's potential, and we're just going to get better and better with it. So I'm very open to it.
I agree.
Fantastic. Well, we are coming to the end of the webinar. I would like to give you guys a couple of minutes to introduce your practice and tell us what you do for patients. And I'll start with you, Dr. Chen.
Okay, I'm a New Jersey girl, so come see me if you're in New Jersey. I'm at the Institute of Reproductive Medicine and Science at St. Barnabas. So we have offices in Livingston at the St. Barnabas Medical Center, and we're part of the RWJBH system there. But then we are kind of all over northern and central New Jersey. So up in Teaneck in Bergen County, Jersey City, Hoboken, Clark, and then down by Princeton and Old Bridge. So, we have 8 doctors. We're going to have 11 by the end of the year. So we're happy to see you and talk with you about freezing eggs or, anything reproductive.
Thank you so
much. And follow me on Instagram. I hope you guys saw it. Hopefully you saw all my little posts.
Thank you so much. Dr. Brown?
Yeah, my name is Dr. Samuel Brown. I'm the medical director of Brown Fertility. We're a large IVF reproductive endocrinology unit in Florida. We're probably the second largest in the state of Florida with volume, and offices through Tampa, Orlando, Daytona, Tallahassee, Jacksonville, all of Central and North Florida. And we're enjoying great success rates, and we're making it affordable.
Thank you so much. Dr. Richlin?
So I'm Spencer Richlin at RMA of Connecticut, Reproductive Medicine Associates of Connecticut. We're in Danbury, Norwalk, and Stanford, and Trumbull, and all in Connecticut, Fairfield County area, and also opening an office in Harrison. We love to take care of our patients. We have really cool people helping us with nutrition and acupuncture and reproductive care and trying to take good care of our patients. Love everything we do that we've talked about. We do. Like Dr. Chen, follow me on Instagram. I started a podcast. I love to give of myself and talk about this for other people because I think it's so important for people to know and be proactive about the reproduction. And that's what this is all about. And so thank you very much for having me on.
So much. Dr. Maas?
Hi, my name is Dr. Kevin Maas. Thank you so much for having all of us. This has been great. I'm one of the partners at the Idaho Center for Reproductive Medicine. We're based in Boise. We're not as big as the other centers, but the problems we're talking about are universal. We're all dealing with patients with basic fertility problems, patients who need fertility preservation on a more emergent basis. And, our clinic provides all the same services as the other clinics on the panel. And, I think we all, I think it's obvious from kind of all of us, we feel strongly that we're providing a really important service that's giving hope to patients who are having a really difficult time. And I do think it's something, it's something where lets people focus on kind of the long-term picture. And I think there's a lot of therapeutic benefit to doing that. So thank you for having all of us on.
Thank you. Thank you. Thank you so much for your valuable experience. We are coming to the end of the webinar on fertility preservation for cancer patients. Next week on Wednesday, April 14, 3 p.m. Pacific time, we will have another webinar, this time on does Pgta improve IVF outcome? Thank you so much, and I will see you next week. Thank you.